Um, really feel lucky to be amongst my esteemed colleagues and a wonderful audience. So the talk that I'm going to deliver is not just for our patients, it's for every one of us in this room as well. So I would really like to emphasize this point. So what is this new form of PCI? So we, in our regular adult practice, even though many of you are pediatricians here, deal with patients in their 5th, 6th, 7th, or 8th decades of life when coronary artery disease or atherosclerotic disease becomes symptomatic. You know, you may have a patient come in with stroke or acute coronary syndrome or angina, peripheral vascular disease, and we are very good at treating it. We can do vascularization surgically, percutaneously, or deploy medical therapy. Well, what about patients, majority of us in this room, who are here? And then what about our children? Is there anything that we can do at this stage of life to prevent what happens to us when we are in our 5th, 6th decades onwards? Well, so the topic that I'm going to explore today is preventive cardiovascular imaging. So that's the second PCI. And then what about our kids? Is there anything to be done over there? And there is a lot of data coming out about primordial cardiac risk inhibition, which is the third form of PCI. And I'm going to try and cover these topics in the limited time in this talk. So basically, we are shifting from intervention to prevention. And basically, we are shifting from when we deal with most of our patients in this stage, when the plaque ruptures, to an earlier stage, when it is present, but it needs to be detected, and we do not detect it, and so we basically mistreat our patients. So we all know about the concept of primary and secondary prevention, right? People who have risk factors for cardiovascular disease, you're all familiar with. At the bottom of this pyramid, we treat them for primary prevention, and then when somebody comes to you with symptomatic cardiovascular disease, we then start our secondary prevention, and we are very good at both treating the acute syndrome as well as doing the secondary prevention. But is there a stage in the middle, right about here, when we have the disease but it's not manifest yet clinically and we have the opportunity to detect it? And what I'm going to focus on today is carotid and femoral ultrasound and some on coronary artery calcification, because these are the two widely used modalities to detect atherosclerosis in its subclinical stage. So in my view, and many people who are in the same thought process like I am, secondary prevention can then begin when you detect subclinical atherosclerosis, instead of still leaving the patient in primary prevention mode. So we are all very good from A to D. We all know what are bad things, what are risk factors, and we try and make our patients understand this and treat this. But how good are these risk factors in actually detecting an individual patient who's at high risk? So this is a study, it's an old study from 2003, but there have been similar data replicated with more newer ways of assessing cardiovascular risk, be it BASCBD risk calculator. Prevent is too new for them to do anything with, SCORE or any other calculator that people use, that if you took young patients who come with MI in your coronary care unit, how many of these patients, how do I go back? How many of these patients, if you had seen them a week before their event in your clinic, you would have actually considered as high risk? And the answer is less than 30%, less than 25%, because they are like you and me sitting in this audience who generally fall under 5% or at the most a little bit higher than 5%, and so you ignore them. But these are the very people who comprise the majority of acute coronary syndromes and cardiovascular deaths that occurred throughout the world. So let's talk about coronary artery calcium. We have been using this for many decades. We know that ideally the coronary calcium score is 0, and then as you go above it, your risk escalates. And there have been some very good studies. I'm just going to show you one example. to show that as you go above the score of 0, you have graded increase in your cardiovascular risk, which starts at about a risk of score of 100. And 300 and 400 and above, the risk becomes tenfold higher if you're basically a statin naive individual. And so in this study, you can see that cumulative major cardiovascular events are about 7% in those patients whose coronary calcium score was more than 300. And if you include the softer cardiovascular events, and the risk increases to about 11-12%. So in 5 years, a risk of 12% will become 10 years, 24%. And we know that that is a pretty high risk by any standards. But what is the probability of finding that coronary calcium in people in this room, for example? Well, so this is a study that I had an opportunity to review. Large database from United States in centers who do a lot of preventive coronary calcium imaging. And obviously these patients are primary prevention population who basically came for their coronary calcium scanning referred by their physicians. And what they found is that if a woman has no risk factors, then if you are looking for a 25% likelihood of coronary calcium being more than 0, then you really have to start at age 58 for a woman and 42 for men. And as these men and women start having risk factors, and especially if they have more than one risk factor, then that age where there is a 25% chance that you will pick up any coronary calcium progressively decreases. So about 9 years in women and about 36 years in men. We wrote an editorial on this paper, and I'm not going to go into the details, but just wanted to tell you that you don't find this in young individuals when you want to detect this disease. And so we did a small study when I was at Cedars-Sinai. We had a group of patients who had both carotid ultrasound, preventive carotid ultrasound, and as well as coronary calcium. And these are generally low-risk individuals. And what we found was that 40% of people had 0 calcium, 40% had more than 0 calcium. But when you looked at the plaque, I think this is run out of battery. Plaque was present in about 60% of patients. And if you included just the thickening of the arterial wall and plaque, then about 70% of patients had underlying cardiovascular disease. This mean age of this population is 54 years. And these are all low-risk patients. And so this prevalence, obviously, I was amazed to see how prevalent plaque and abnormal carotid arteries were. Thank you. And interestingly, what we found was that in those patients who have a coronary calcium score of 0, about half had carotid plaque. So you can't just stop at one vascular bed. You've got to look at multiple vascular beds in order to detect disease. And you can, and 0 calcium does not mean there's no soft plaque, and 0 calcium does not necessarily help you in younger individuals. And the situation is even worse with women. So this is a study that was conducted at my center when I hadn't joined the center yet. And they found that coronary calcium score was 0 in 67% of women, but 58% had carotid plaque. So plaque obviously is comprised of both calcium and non-calcified structures, number one. Number two, it probably develops earlier than by the time the coronary plaques begin to calcify. So if you have to look for earlier disease, you have to think beyond coronary calcium if it's not giving you the answer. And the same data has been replicated by larger studies. This is the data from bioimage study from Valentin Fuster. And you can see that low-risk people, juggling with these, low-risk people had about 50% chance of having plaque in at least one of the 2 carotids or having a coronary calcium of more than 0. And then obviously as the risk grows, the prevalence of plaque grows. It's not just this concept of looking at multiple vascular beds is not new. It was used in a study called Rotterdam study, where they looked at the top panel over there, carotid wall thickness, carotid plaque, ankle brachial index, and any calcium on chest, on abdominal aorta, and found that as you progressively increase the number of these vascular beds, the outcome, the event-free survival, which in this case is acute myocardial infarction, progressively goes down. And each of these variables had significant predictive value, which was independent of each other. And if you combine them, like if you have atherosclerosis in more than one vascular bed, then your risk goes significantly higher, about threefold. So how do we actually look at carotid ultrasound? I'm not talking about carotid duplex here. I'm talking about non-stenotic plaques in majority of patients. So this is what a normal arterial wall should look like. Oops. You can see that there is no plaque, and we're just measuring the wall of the carotid called the intima media thickness. Here the wall is irregular and thick, so this is what they call grade 2. Now the wall is thin, but you have a focal plaque. This is grade 3. And you have extensive stenotic plaque, which is grade 4. And they did the same thing for femoral bifurcation. And what they found is that of the 10,000 patients who completed a 10-year follow-up, majority of events occurred in those patients who had type 3 and type 4 plaques. You can see that they only comprise a very small percentage of the population. 80% of population with grade 1 plaque had very low event rate. So it predicts cardiovascular events in the long term. And if you look at the European guidelines, which is I think what really people here follow more than the American guidelines, after the resting ECG, which is in green, carotid and femoral ultrasound should be considered for plaque detection as CV risk modifier. Are we doing it? Probably no, not for this particular purpose. And then look at this calcium scoring is much lower down than the and then carotid intima media thickness. Multiple studies have shown that it doesn't really help, and so I agree with this. We have found the same data. This is the American guidelines. American guidelines are generally very behind the European guidelines, and I personally tend to follow the European guidelines when it comes to atherosclerotic heart disease. And there are multiple reasons for why the American guidelines are the way they are. And if you're interested in knowing, this is a review article I wrote way back in 2014. There are multiple reasons why CIMT is not a predictor, is because of the way we do CIMT. And that's really the bottom line of this review article. Now, does it actually help to detect it in our clinical practice? So let me give you some data from our own work that we recently published. What happens at my center is patients come for cardiovascular preventive visit. They are fine, asymptomatic. The doctor refers them for carotid ultrasound.
2 minutes remaining.
2 minutes, okay. So bottom line is that this is the result we found, that if you had 3 plaques, then your chances of having cardiovascular events at the end of 12 years are significantly higher compared to if you had either no plaque or 1 plaque. And then I'm going to show you some examples. This is a 66-year-old man who's coming for a preventive clinic. He had mild calcium on his chest CT. It was done some other reason. He's been on Lipitor. Gets a carotid ultrasound the next time, and look at the number of plaques that he has in multiple areas of both the carotids. This is a patient who had a calcium score of 0 in 2022 and comes to us in 25. And look at the pictures where the green arrows are full of plaque in the carotid arteries. Plaques progress and plaques regress. That's the best part of it. So I'm showing you the example of a patient's demographics have not changed that much, except the patient is a little older. Hemoglobin A1C is a little higher, and the weight has gone up by 1 kilogram. But look at what effect it has on the plaque that is much bigger now. This is another patient on the left in 2020 and 24, much more plaque. This is an example of a patient in whom plaque regresses. What are the modalities that can show you that in 2023, look at the plaque area, and in 25, a distal part of this plaque has been eaten up. And so there is data by Valentin Fuster's group that of those patients who regress their plaques right about here, Something is not right here. Okay, yeah. So those patients who progress, they are the ones who have worse outcome. I'm going to quickly move on to my grandson, who I'm missing a lot, primordial prevention. So I gave him instructions about salt not being good for you.